Dr. Jae Moon, a fertility specialist here at Maria's Fertility Hospital. Last time we talked about what infertility is and the tests needed for diagnosis. In today's video, we will talk about what treatment options are available to overcome infertility. To fully understand this, we must first understand how pregnancy is achieved first. Every month when menstruation begins, hormones in the female body work together to develop mature follicles. Only one of these advances into a dominant follicle and releases an egg into the salpinx on the day of ovulation. When this egg meets sperm in the salpinx, fertilization occurs and a well-made embryo will travel down from the salpinx to the endometrium. If the endometrium is thick enough, the embryo will implant itself and pregnancy will succeed. If for some reason, however, implantation fails, the thickened endometrium will collapse and be discharged as menstruation. Pregnancy consists of 3 steps: ovulation, fertilization, and implantation. If any of these does not happen, it is not possible to get pregnant, which is why finding the cause and fixing it is important. If it can't be fixed, different types of procedures and medication can help. Now we will take a closer look at each of these techniques. As mentioned earlier, an egg must meet sperm in the salpinx for pregnancy to happen. However, because ovulatory dysfunction is one of the most common causes of infertility, most women fail to regularly ovulate every month. In this kind of situation, we can use medication to help women ovulate, which is called ovulation induction. The same medication can be used for women who have no problem with ovulation. In this case, because only one egg is normally released every month, ovulation is done to release more eggs from both ovaries, thereby increasing the chances of eggs meeting sperm and thereby increasing the chances of pregnancy. This is called ovarian hyperstimulation. Therefore, both ovulation induction and controlled ovarian hyperstimulation are done in women in Maria's Fertility Hospital. Different drugs can be used for ovulation induction. Oral drugs include clomiphene citrate and Femara, but the most commonly used one is clomiphene, which is inexpensive yet safe and effective. It is taken usually for 5 days at a similar time every day, starting from the 2nd day of menstruation. Side effects are rare but can appear as headache, nausea, vomiting, abdominal discomfort, flushing, and visual impairment. However, most side effects go away once stopping the medication. In some cases, the endometrium may become thinner after taking clomiphene, which may hinder implantation. In this case, Femara is started from the next cycle. Aside from oral medication, subcutaneous injections can be used. The commonly used injection is a follicle-stimulating hormone drug, which increases the concentration of the said hormone by directly injecting it into the body, leading to ovarian hyperstimulation. If the cause of infertility is ovulatory dysfunction only, natural pregnancy can be achieved solely with ovulation induction or controlled ovarian hyperstimulation. As explained earlier, clomiphene can be taken for 5 days, and ultrasonography can be used to check the endometrial thickness and size of ovarian follicles. If multiple follicles have grown enough, sexual intercourse can be done near the day of ovulation. If needed, an extra drug to trigger ovulation may be given. This method is called timed coitus. Next, we will check out intrauterine insemination. Shortened to IUI, this is a procedure in which semen is directly injected into the uterus, thereby increasing the number of sperm reaching the salpinges and thereby increasing the chances of fertilization. Like timed coitus, either ovulation induction or controlled ovarian hyperstimulation can be done, and ultrasonography is done routinely to check for the endometrial thickness and ovarian follicle size. If at least 3 ovarian follicles have matured, an injection to trigger ovulation can be given, and IUI follows 2 days later. On the day of IUI, the male sperm will be collected in advance and prepared in the lab, where only the sperm with the best quality will be transferred. When the semen is ready, the doctor inserts a small catheter into the uterus and slowly shoots the sperm inside. This is a simple procedure that does not require anesthesia, which is why the patient can go home right after. IUI can be performed in different situations. It can help increase pregnancy rates in women with endometriosis, ovulatory dysfunction, or cervical factors which make it difficult for sperm to swim inside the uterus. Similarly, IUI can also be done in cases where male factors cause infertility, such as abnormal sperm production or poor sexual function, which decreases the chances of sperm reaching the salpinges. Other than that, IUI can also be a treatment option in couples with immunological or unknown causes of infertility. So as long as there is enough sperm, the success rate of IUI per cycle is approximately 8.2%. Because foreign materials enter the uterus, infection or vaginal bleeding may occur. Excessive ovarian induction or hyperstimulation may cause ectopic pregnancy, multifetal gestation, or ovarian hyperstimulation syndrome. Next, we will talk about in vitro fertilization and embryo transfer. In vitro fertilization refers to the method of collecting eggs and sperm and fertilizing them outside of the human body. First, either oral medications or injections are given for controlled ovarian hyperstimulation. After multiple ultrasonography sessions are done, when enough follicles have grown to a certain size, an injection is given to trigger ovulation, and ovum pickup is done 2 days later. Ovum pickup, the procedure of collecting eggs by sono-guided transvaginal aspiration of follicular fluid using a needle, is done under light sedation. At a similar time, male sperm is collected and processed in the lab, after which it is used to fertilize with the gathered eggs. When fertilization is successful, the embryos are transferred into the uterus. Embryo transfer is the transplantation of the embryos made through IVF into the uterus. This technique can be done with either fresh or frozen thawed embryos. While fresh embryo transfer refers to the transplantation of embryos made in the same cycle as ovum pickup, frozen embryo transfer means freezing the embryos first for some reason and then thawing and transferring them at a later appropriate time. Embryo transfers do not require anesthesia. Under either transvaginal or transabdominal sonoguidance, a thin catheter is inserted into the uterus through which the embryo passes through and implanted. This procedure is usually completed in 5 minutes. Because IVF is usually a last resort, it can be tried when IUI fails at least 3 times. Or it can also be done in cases where women are less than 35 years but have gone through infertility for 3 years. Or it can be done at the first time when women are older than 40 years old. Other than that, IVF can also be done in situations with low sperm count, both tubal occlusion, severe endometriosis, persistently failing ovulation induction, or prolonged infertility caused by cervical or immunological factors. Upon reaching the age of 40, the success rate of IVF drastically drops. When success rate equals birth rate, the birth rate per cycle at age 30 is 17%, but drops to 7% at age 40 and all the way to 2% at age 45. Similar to IUI, some complications of IVF include vaginal bleeding, infection, OHSS, ectopic pregnancy, and multifetal gestation. Of these, ovarian hyperstimulation syndrome, also called OHSS, may sound unfamiliar. This is a condition characterized by enlarged ovaries and ascites. In severe situations, pleural effusion and thrombosis may follow, which may be life-threatening. Also, unlike IUI, because IVF uses needles for aspiration, internal bleeding may occur. In summary, we can try ovulation induction or controlled ovarian hyperstimulation, intrauterine insemination, or in vitro fertilization with embryo transfer. But there is a whole lot of various technology that can be additionally applied to each of these methods. In addition, there are also small to big procedures that can be performed depending on the cause of infertility. For example, bilateral salpingectomy is considered in bilateral tubal occlusion with hydrosalpinx, and hysteroscopic operation may be an option in cases where implantation continues to fail due to the presence of a submucosal myoma, polyp, or intrauterine adhesion. Today, we learned about infertility and treatment options. Having a baby is not the most difficult thing to achieve, but with perseverance, we can make that happen. Come visit Maria's Fertility Hospital, and we will find a way to help you meet your beautiful baby. Thank you.